Hi guys, welcome back. The next topic that we're going to study is Alzheimer's disease, which is one of the leading causes of cortical dementia slash senile dementia. The condition of these patients subsequently will become so bad that they not only would be forgetting everything, including their name, personal details, mobile phone number, but they would not be able to even tell that they need to go to the bathroom. In fact, sometimes they may not be even able to feel that they need to use the washroom, so they might be urinating in their pants. They might be defecating in their pants, and they will not even mind the bad smell. Alzheimer's disease patients are one of the most, I would say, unhygienic patients that you will come across. These patients may not have brushed their teeth for long. The beard of these patients will be unkempt. The hair would be long. Nails will be jet black. And he might be wearing the same pajamas for weeks altogether in which he has urinated and defecated. You can imagine the unhygienic status of this chap. Well, I want to highlight that one of the big problems that comes with Alzheimer's disease in the later stages is mutism, and second would be hygiene issues because these patients will not be able to tell that they want to pass urine, so you will have to use a diaper for these patients. Now, when you talk about a concept of diaper in an adult patient, especially in India where resources are lacking, adult family members are not able to comprehend why does my dad or mom actually need a diaper at 75 years of age. Well, they're not as intelligent as you. They're not understanding that this old man is not only having memory issues, but he's also having problems with controlling his body functions. So this disease is a horrible disease to have in a family. And I would like to mention names of two important politicians. One is our former defense minister, Shri George Fernandez. He suffered from Alzheimer's disease, well documented. And second, one of the best prime ministers that we had, Shri Atal Bihari Vajpayee, he won the Kargil war for us. But after 2004, you never have read about, or I would say, you would have never seen Vajpayee Saab conducting a press conference. Why? Because he was again having Alzheimer's disease manifestations, though some media reports mentioned that he suffered from stroke and because of which he was not able to speak. But yeah, I mean, the point is that once cortical dementia will occur in an individual, even if it's a big politician, the ability of his to perform routine tasks like taking a press conference or addressing people or taking decisions will definitely be hampered. So let's now study regarding what are the neurotransmitters which are going to be compromised in this cause of cortical dementia. You are familiar with acetylcholine obviously, but from the exam perspective where multiple correct options can be present, I want you to remember along with acetylcholine, noradrenaline and even serotonin values are found to be lesser. Then he will ask you which part of the brain is affected. Please appreciate that in Alzheimer's disease, do not answer whole of the cortex is involved. The main two lobes of the brain which are affected in this condition are parietal and temporal. Just remember PT at the moment, parietal and temporal lobes are the major lobes affected. That is where the manifestations will also develop. And when it comes to the temporal lobe, that is where the hippocampus is. That is where the seat of short-term memory is present. In this disease, initially short-term memory would be lost. Then even long-term memory would be lost because neocortex gets involved. But if they ask you to give one single best answer about which area of the brain is involved, it is obviously hippocampus. But specific answer for inside the hippocampus is nucleus of Maynard basalis. In fact, in some MCQs, he might, instead of asking you which area is involved, he might say which is the site of the brain where earliest damage is present. Or the question can be changed as most severe damage is encountered in Alzheimer's disease in which part of the brain. You see, the usual impression of most of the doctors is that it is a diffuse cortical disorder, whereas that is not the case. Actually, it's mainly the parietal and the temporal lobes that are mainly involved. So the earliest part as well as the most severe damage is actually encountered in the temporal lobe. And then he can also say lateral temporal lobe and medial temporal lobe. So your answer would be given as medial temporal lobe. I want to reiterate the facts. There are two answers for which parts of the brain are mainly affected: parietal, temporal. If they ask you to select one, it is temporal lobe. If he says medial temporal versus lateral temporal, your answer is going to be what I've just written at the moment. That is the medial temporal lobe. Or in some questions, he would like to mention some more anatomical terms. So even medial temporal lobe would be missing. And then you would be answering the word anterorhinal cortex. These are three standard opening details that I want you to remember for this topic, where apart from memory loss, even the hygiene issues would be compromising the quality of life of this individual. Alzheimer's disease is a leading cause of cortical dementia slash senile dementia. In fact, recently in the INICT exam, they had asked regarding cause of cortical dementia apart from Alzheimer's disease. I hope you are familiar about this even from the psychiatry domain, that Pick's disease, which is nowadays called as frontotemporal dementia. Now see the words. In Pick's disease, it is frontal and the temporal lobes that are predominantly involved, whereas in Alzheimer's disease, it is the parietal and the temporal lobes that are involved. I'll just write the word PT at the moment so that you can remember it. Whereas Pick's disease also has cortical dementia. Now, the query that will come from relatives and obviously the examiner as well will be, why does Alzheimer's disease develop? So it is going to be chromosomal reasons behind it. I mean, it's not that all of us when we are old will develop Alzheimer's disease. Only some people would be having a genetic predisposition for it. So he would love to ask you the genetic component related to the following chromosomes where defects could be present. That could be chromosome 1, 14, 19 and 21. Let's go one by one on the genes. If chromosome 1 is defective, the gene that is the troublemaker in this case, and we will also study what this defective gene will cause, is presenilin 2. Whereas for chromosome 14, it is presenilin 1. The concept is that presenilin 1 gene is not related to chromosome 1, it is related to chromosome number 2. So these are the two genes that I wanted to remember. Moving to chromosome number 19, a very interesting term, apolipoprotein E. That's itself a term that you need to remember, because normally we read about apolipoprotein A, B with respect to lipid metabolism. Apolipoprotein A gene is what I wanted to remember, and then there are alleles of this. The alleles would be like ApoE2, ApoE3, ApoE4. So I wanted to remember that those with ApoE4 allele would be having a higher tendency to have this disorder. Chromosome 21, well, I'm talking about Down syndrome. Patients of Down syndrome in India can die because of pneumonia or can die because of congenital heart disease like ASD present. But yes, if they survive up to the age of 35 years, they can develop dementia. I said a very surprising term. I said if they survive up to the age of 35 years, then they can develop features which can develop in Alzheimer at 70 or 80. This chap can develop these manifestations as early as 35 years of age. So this is itself a question that in which condition would you be having presenile dementia? Your answer would be Down syndrome. In this case, you also need to remember regarding amyloid protein, which is asked, that is APP, that is amyloid precursor protein. Though these details are discussed even in the pathology component, I just want to reiterate the fact that these are the 4 reasons why it would be occurring. Now let's gonna look at what's gonna happen inside the neurons. If this is the representation of a neuron per se, and let me say this is another one, this is the nucleus of each one of these with dendritic processes, then between these neurons there would be deposition of what is called as amyloid protein, and this amyloid protein that is deposited is called as A beta. I am very sure that from the kidney discussion in the earlier part of the app, you are familiar with the fact that A beta 2 amyloid deposition in the brain is responsible for development of dialysis dementia, the one that is associated with hemodialysis, but A beta is related to Alzheimer's disease. The term neurofibrillary tangles. Neurofibrillary tangles are present inside the cytoplasm of the neuron of patients of Alzheimer's disease. The green representation here is that of neurofibrillary tangles. They are the intracytoplasmic finding of these patients, and the number of neurofibrillary tangles directly correlate with the severity of dementia. Mark my words here, guys. It is not A beta amyloid which is related to the severity of dementia. A beta amyloid is just an associated finding that is extraneuronal. In old people, even if they don't develop Alzheimer's disease, still A beta amyloid can be present. A beta amyloid is just an incidental finding. It does not decide the severity of dementia. It is the intracytoplasmic finding that decides. I can just show you an image here also, which is, I would say, simplification of the histopathology images that can be given to you. You see, whatever you see outside is called as amyloid plaques. Those are A beta amyloid. But it is inside that where the neurofibrillary tangles are present, and these neurofibrillary tangles are related to a protein that is called as tau protein, and that is why when you read about taupathy, Alzheimer's disease per se would lead the list. In Parkinson disease, I've talked about alpha-synuclein protein. So lots of time you will read the term alpha-synucleinopathy, but in this case you will read the word taupathy. These are two histopathological findings which will develop secondary to these genetic reasons that I mentioned, and two great politicians that I mentioned, that India's had very fortunate that we had a very good defense minister, then we had one of the most, I would say, dynamic prime ministers that we had, and we lost Vajpayee Saab to pneumonia, no? Right? Because ultimately these patients will become bedridden. And once they become bedridden, then lung infections can definitely come in. So you would have read news of Vajpayee Saab getting admitted to hospital in 2016, 17, and we lost him in 18 because of the extensive pneumonia component. And that's the end result in most of the neurological diseases which contribute to severe disability. Let us now talk about what are the clinical manifestations that will develop in the disease, and you can remember them by the mnemonic 4A's. In 4A's, the first A component is amnesia, that is forgetfulness. Now, how would the patient present? You see, he would be having loss of episodic memory. Now, episodic memory is like you know how far the grocery store is away from your house, so you know the way to the grocery store and back. This guy has been living in this colony for 70 years. He goes to a particular grocery shop for last let me say 60, since age of 10 years. His mom, when this old man was himself a child, his mom started sending him to get little bit of items like, let me say, tea or coffee or sugar or eggs or bread for breakfast. So for 60 years he has been going to the same shop, and now this old man will go to that shop and forget why did he come. Even if he buys products from there, he may not even know the way back to his house. He has lived at that colony, he has lived at that street for so long, and now this old man does not even know the way back to his house. So episodic memory basically means that this old man will develop inability to do basic things that we don't even think about, like for example track finances. Normally you would have seen old people are very particular about money aspects. If an old man will go out with 500 rupees in his pocket, he will know that, okay, I'm carrying 500 rupees. If I ask you how much money are you carrying in your pocket, you would just put hand in the pocket, take out some money and put it on the table. You don't even know what you are carrying, because we as young people, or rather you as young people, will not even bother about it. But old people are very particular and very meticulous, because they have so many years of experience with them. So they would be knowing how much money are they carrying, how much did they pay the vegetable vendor, how much money did I pay at the milk booth, how much money did I pay to XYZ Dhobi, etc., whatever, right? Or maid per se. This guy will lose ability to track finances. Why I'm emphasizing that is because people with Alzheimer's disease, if you hand them over their internet banking password and the user ID, and they start making transactions by themselves, they might actually make wrong transactions. They might actually transfer their whole wealth to somebody. In fact, there have been instances when people with early onset Alzheimer's disease have lost their entire wealth to some kind of a scammer who just called them up, talked to them, and asked them to transfer the money. And the person would gradually transfer the money, because he's not realizing that numbers is something which is going to be mind-boggling for these people. So the message is that inability to track finances, inability to drive, and driving, say, I don't mean the fact that he can't press on the accelerator of the car and put on the brakes. He might drive safely, but he might not be able to get back to his house. So he might get lost. So all the routine things about which we don't think about, like how much money are we carrying in a pocket, how much did I pay somebody, how much is left behind in my pocket, episodic memory facts would be lost. Subsequently, there would be loss of short-term memory. Short-term memory would be like he put his cell phone in his left breast pocket. Now he's hunting for the mobile phone in the whole of the house. His daughter is laughing. Dad, mobile phone is in your left breast pocket and you are hunting for mobile phone. Initially, it's a laughing matter for everybody. It is only later that they realize that the same person got lost, and he cannot even remember his name. He cannot remember his address. He cannot even remember his cell phone number. So you have episodic memory loss, you have short-term memory loss, and then you have is a long-term memory loss. Mostly non-medico people, his son and daughter, will realize that there's something seriously wrong with this old man when he went off his house for, let me say, getting grocery items, and he did not come back. So maybe the grocery shop owner took mercy on this guy. He said, okay, this old man is sitting outside my shop for 4 hours. And you see, normally these grocery people, they usually know which person stays in which house. So he said, sir, can I just escort you? So this guy will smile back at him. This old man will smile back at the grocery owner. So the grocery owner will not realize that there's something wrong with this guy, because social graces are initially maintained. Like if I'm talking to you in a nice fashion, you'll obviously smile back at me. I mean, a harmless smile really does not cause any harm to anybody. This guy, social graces will be maintained, but the unfortunate thing is that it's not going to register in the brain that this guy, the shopkeeper, is offering him to take him to his house. He might have to hold him by his hand, escort him to his house, saying that he's sitting outside my shop for 5 hours. And when his son, daughter, or wife is asking, what really happened? We were so concerned about you. He's not answering. This person is having aphasia because of damage to the dominant parietal lobe. Please remember, Alzheimer's disease patients do not have acalculia, they have dyscalculia. They make wrong calculations. If you say transfer 1000 rupees to me via online banking or via Paytm, he might transfer 10,000 rupees. That is dyscalculia, not acalculia. Acalculia is a feature of stroke. Dyscalculia can be found in patients of Alzheimer's disease. And well, we doctors are also bad at mathematics, no? That is why we took up biology and became doctors. So that does not mean that we have Alzheimer's disease. I basically want to sensitize you to the fact that in some books, some guides, some apps, it is mentioned acalculia as one of the features of Alzheimer. No, it is dyscalculia. It's not a diagnostic feature. I mean, I am bad at mathematics, right? I took up biology because of that. That does not mean that I have one of the diagnostic features of Alzheimer. It is amnesia, then is aphasia due to damage to the dominant parietal lobe. Then you can be doing a clock face test in this patient. Like for example, you can draw a clock. You can mention hours like 12, 3 o'clock, 6 o'clock, 9 o'clock. And you can draw in between like this. And then you can draw the needles also, one big one, relatively small one. And you can say, sir, can you draw for me? When you do this clock face test, you will notice the fact that there is a distinct possibility that this person with Alzheimer's disease might put all the numbers like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 on one side only. I'm not teaching you hemi-neglect. He might just draw one needle, only half the clock timing orientation has been made. What I'm teaching you at this moment is loss of visuospatial skills in a person. Like if I draw a geometrical shape before you, I say, can you please draw a triangle? Like I'm not saying only drawing a triangle, I'm drawing it before you. Say, doctor, okay, copy these geometrical shapes before me. You easily can draw these geometrical shapes because your parietal lobe is working just fine. You have visuospatial skills, but in this guy, the non-dominant parietal lobe is affected. So visuospatial skills would be lost. The test that I did before you guys is technically called as clock face test. Actually, there has been a question in the exam where they have given a clock face test like this and they've asked what does it signify. It signifies that there is a loss of visuospatial skills in an individual, which basically means apraxia. The fourth feature of the disease, which is the highlight, and I'm using a different ink to highlight it, is called as anosognosia. Well, the meaning of this term is that this person has passed urine in his pajamas, stool in his pajamas, he's smelling of feces, but he does not mind the bad smell. Forget about trying to change his clothes and washing himself clean. He will sit as if nothing has happened. His son and daughter are frustrated that my dad has become so unhygienic. He's urinating on the floor in the house. He's not even making an attempt to clean it. Forget about cleaning the floor. He's not even trying to clean himself. In fact, guys, in Alzheimer's disease, the situation is so bad that if you place a plate of food in front of this guy, he does not even know that how to eat the food. Even if you have mercy on this guy, like in your ward, there was an Alzheimer's disease admitted patient with pneumonia, for example, and the hospital staff just put food in front of him and went away and he's not eating. So you thought, okay, let me just feed the old guy. So you took a spoon, picked up some rice, put it in the mouth of this guy. You are putting food in the mouth of this guy. He does not even know that he has to chew. And when you put food in the mouth, obviously there would be some salivation. So there would be saliva coming from the mouth. There would be food dripping from the corner of the mouth. And then you will notice that there's a wet patch appearing on the pants of this guy. You are feeding him and he's urinating in his pants. So you can understand the frustration from a non-medical perspective, because US doctors can understand he needs a diaper. He might require a tube feeding. He might require a feeding gastrostomy or maybe a feeding jejunostomy, because nutrition part is obviously to be taken care of these patients. You see, in America, there are nursing homes where these old people are kept. And you would have read anyway, a lot of these old people with Alzheimer's disease in America, they actually died because the caretakers of these people, they suffered from COVID-19. They were young people and they transferred it to this old man who could not feed by himself, and the Alzheimer's disease patient died then subsequently. The 4 A's of the disease are amnesia, aphasia. Aphasia is a feature of dominant parietal lobe. Apraxia, non-dominant parietal lobe, identified with clock face test, and anosognosia, which basically means that there is lack of awareness. with respect to hygiene issues in these patients. Though there is lack of awareness to almost everything. It's not that he's an altered sensorium. Sensorium is fine, but there is lack of awareness, especially of the hygiene issues in these patients. So it's a very difficult thing for non-medical people to understand that why is his or her dad become relatively so unhygienic. The next features might actually surprise you, but you need to remember that in the later stages of this patient, there might even be development of rigidity, not the classical rigidity that you encounter in Parkinson disease, the cog wheel type or the lead wheel type. But at the same time, I mean, yes, rigidity will be written in the literature. Later stages, the person might actually be totally mum. He will be obviously incontinent. So there's a possibility that he may not write the word anosognosia. He might write incontinent patient. And then the person will become totally bedridden. Once the patient is incapacitated, then so many more other problems will come. You see, if somebody keeps on lying in the bed for most part of the day, there is risk of deep vein thrombosis. There is risk of pulmonary embolism, risk of UTI in this guy, and God forbid if he develops a bed sore and he's urinating over that bed sore itself. No, he will urinate in the bed, so the urine will soil the bed sheet and the bed sore also, and that is when sepsis will come in and the person can die. So incapacitated, bedridden state is usually found in the later stages of the illness. So I would say that most neurological illnesses end up in a sad way. I shall now be explaining to you regarding the workup of a patient of Alzheimer's disease, where the first test that would be done is called as MMSE. That is mini mental score examination, which you read even in psychiatry. You see, per se, from the Indian perspective, patients may not be very comfortable with questions when you say which month is going on, because a person from rural India may not be able to say January, February, March, etc. So you have to you obviously interpret the perspective in the local language of the patient. But yeah, a person should be able to tell you which year is going on, what is the month, what is the date, or like in Indian perspective, you can ask about festivals per se. Then you will ask the patient to do some basic calculation like serial subtraction. You can see in the form it is mentioned that we are asking the patient to subtract 7 from 100. Whatever value will come, you will again ask the patient to subtract 7. So serial subtraction is to be done. Then recall of 3 items, like you can say mango, apple, and then you can maybe talk about any geometrical shape. So ask him a quick recall. These are some of the aspects which you will ask the patient to perform. Like you are here asking the patient to draw two intersecting pentagons, that is visuospatial skills are being tested, and you and me can draw an intersecting pentagon, or you can draw a 5-shaped geometrical shape, but a person with Alzheimer's disease on account of apraxia will not be able to do these tasks. The total score in mini mental score examination is 30, and if a patient gets less than 24, we say he has dementia. Please remember, 21 to 24 is mild dementia, 10 to 20 is moderate dementia, and less than 10, the patient will be so unhygienic that even a non-medico son and daughter will say, "Sir, does my father have Alzheimer's disease?" I want to highlight the fact that there is no big deal if you diagnose Alzheimer's when person is having a score of less than 10. I said at that point of time, the condition is going to be so bad and this old man will be so forgetful that even a non-medico can relate to the illness of the patient. It is the earlier identification that is obviously recommended. Mini mental score examination should be remembered as a screening test for this condition and not to be answered as investigation of choice. Why? Because it can be having a false low score, like the score might turn out to be 20 even in a patient of depression. So if he says what is the best way to confirm that this person is having this disease, then ideally you should answer functional MRI. You can answer a PET scan also, but in the exam, he will make you compare the various types of MRI like functional MRI, diffusion weighted MRI, plain MRI. So if the comparison is between the various types of MRI and MRA per se, then it is functional MRI which is to be done. The point is, he's going to make you compare the various types of MRIs only. So otherwise, you can do a PET scan also. Functional MRI on a comparison basis will help you identify that the metabolism that is occurring in two parts of the brain, that is the parietal and the temporal, is obviously not optimal. Don't be under impression that whole of the brain is involved in Alzheimer's disease. Yes, I did say the word neocortex, but mainly it is going to be parietal and temporal lobe. Why is the answer not plain MRI? Well, plain MRI will be showing findings very late, because in this condition there will be blunting of the gyri and the sulci. So therefore, one of the radiological finding that will appear in this person will be that of enlargement of the ventricles of the brain. You see, I'm writing the word pseudo enlargement of the ventricles of the brain. It might look like you are actually seeing a CT of a person or MRI of a person who's having hydrocephalus. This guy is not having a hydrocephalus. The ventricles are looking bigger because the gray matter of the brain has thinned out. So on a comparison mode, functional MRI will be relatively a better answer. When it comes to treatment of these patients, the drug of choice will be answered as donepezil. Along with that, a new drug that you need to study from pharmacological domain is memantine. Lots of time in practice, you would have seen that we are not starting with donepezil. That is the drug of choice, considering the fact that it works in the severe variety as well. Lots of time in the initial part of the illness, you will see physicians writing rivastigmine for these patients along with galantamine. It is only later that a psychiatrist will come in the picture. Most of the time, the diagnosis would be made in a medicine unit, probably in a neurological unit, and then subsequently the referral to the psychiatry department might occur. When it comes to tacrine, you would have done a question in pharmacology that it has been withdrawn from the market because of the hepatotoxic potential per se. So the drugs component is definitely which I want you to be rock solid in. And today I have tried to highlight that the best way to identify this condition is not a mini mental score examination, because as I told you, false positives can definitely be obtained, especially with the case of depression. So it is neuroimaging that would be done, and there's so many varieties, no, volumetric MRI, functional MRI. So yeah, I mean, we definitely can do a FDG glucose PET. PET can definitely pick up the metabolism aspects, but most of the time in the exam he will compare the MRIs per se, so then functional MRI would be the answer. I have today tried to emphasize before you that the leading cause of senile dementia, which would be having cortical atrophy, is Alzheimer's disease. Make no mistake that if Alzheimer's disease is not in the options, then your answer would be given as Pick's disease, which is also called as frontotemporal dementia. If he says pre-senile dementia, then the answer is Down syndrome. If he says subcortical atrophy, then subcortical atrophy or subcortical dementia is what you read with Parkinson's disease, Huntington's chorea, most importantly, AIDS-related dementia. That's an important one that is usually asked in the exam. So please remember, Pick's disease is to be answered for cortical and AIDS-related dementia for subcortical dementia. Once you have remembered these two questions, you need to remember some combos. If you read a question that is mentioning combination of dementia with myoclonus in a person who's a beef eater, even if it does not talk about beef eating per se, the combination of this in a relatively young age patient should always prompt you to think in terms of variant Creutzfeldt-Jakob disease. He might even aid you by doing a EEG finding that is discussed in the relevant section when I have discussed CNS infections, and also when I have talked about EEG per se. EEG findings of variant Creutzfeldt-Jakob disease like periodic sharp wave complexes have been discussed. If he talks about a patient who's having dementia with chorea and the age group of the person is approximately, let me say, 50 years of age, age group is obviously not a very good way to identify the question, but I'm usually mentioning the peak age of onset with respect to Huntington's chorea or Huntington's disease, which is a disorder of trinucleotide repeats. If he says the word pseudo dementia is a presentation of, then the answer would be given as depression. And that is why in the earlier part I said that MMSE score may not be accurate in patients of depression because it does not feel like answering you. Rather, he might get irritated by your repeated frequent answering. Then some MCQs might actually incorporate pathological terms like Lewy bodies. I've described that Lewy bodies are encountered in Parkinson's disease, but then they can also be found in Lewy body dementia. In contrast, when it comes to Hirona bodies, I did not mention this term earlier, but I'm adding this now to the discussion per se. You can add this to the pathological aspect. Earlier, I was mainly emphasizing on neurofibrillary tangles and A-beta amyloid, the neuritic plaques per se, because they are the ones that are asked. But if he wants to go into hardcore pathology, then even Hirona bodies per se can be asked. I also want you to remember that when it comes to Pick's disease, the alternative term is FTD, that is frontotemporal dementia. Now let us look at what's going to happen if a person is having a frontotemporal dementia. Frontal lobe always causes, or damage to frontal lobe always causes a person to lose social graces. This person will become aggressive. This old man, he might be in a lift and he might actually take off his trousers and he might expose his genitals to people of the opposite gender in the lift. I mean, this guy has been living with these people for so long. Those people are ashamed of what this guy is doing, but he will have no remorse, no guilt. And they're saying, what has happened to this old man? Suddenly, he has exposed himself to his neighbors. So, socially inappropriate things, or I would say he's rather actually committing sex related crime. But at the same time, he's unaware of this. So, such kind of a situation where an old man starts turning aggressive, he starts doing socially inappropriate things. I mean, that's an important hint I want you to remember. Anyway, I've discussed, even in stroke topic, I've highlighted whenever frontal lobe is damaged, the person will tend to be relatively antisocial in personality. Then, even features which are found in psychosis or psychotic episodes might be found in these patients, like OCD can come up. Then delusions can be present, hallucinations can be present. When I was describing per se Alzheimer's disease, I never spoke about such kind of a profile. In frontotemporal dementia, apraxia is usually not seen. The visuospatial skills are usually preserved. I want to highlight this fact. I incorporated apraxia as one of the A's in cortical dementia, but in Pick's disease per se, we do not have presence of apraxia. Though obviously, you will have to evaluate the patient in the sense that frontal lobe involvement can be present. Lots of time in the same MCQ, he might write terms like echolalia, where the person will repeat words. Traditionally, you read about echolalia or echopraxia, where the person will repeat what you are doing. Like you are trying to examine him, he's also trying to examine you. So echolalia is repetition of words, and echopraxia would be repeating actions per se. Please remember, these terminologies would be given in literature with respect to frontotemporal dementia and would not be a feature of Alzheimer's disease. So differentiation is definitely possible. So these are the things that I want you to remember for this topic, and I would like to finish by highlighting the fact that this particular slide that I've just marked out before you is one that is a combination of facts that you study both in psychiatry as well as medicine. So I would like you to specially note down these facts by yourself, put them on a stick-on pad, and try to remember them to the maximum capacity. Thank you so much for your patience and hearing me.